my very enormous pleasure to welcome for the second time personally in Greece to give us a live talk, Prof. Damato, who all know Prof. Damato is an esteemed internationally ocular oncologist. And now, as we know, Prof. D'Amato currently is in Sweden and most recently developed MOLS, a single algorithm that distinguishes benign nevi from malignant melanoma of the back of the eye. And Prof. D'Amato has various awards and official recognition, not only from the National Health System in UK, but from the ophthalmology organization from all over the world. He has published more than 300 articles in scientific journals, 100 textbook chapters, and had authored and co-authored or edited several ocular oncology textbooks. He's a great friend of mine, and today he will speak us on retinal lymphoma. Prof, we are all here for you.
Hello, thank you very much for inviting me. It's a great pleasure to be participating. So I'm going to speak about retinal lymphoma. Can you see my first slide?
Yes, yes.
Good. This is a very controversial topic, but I will be presenting my personal ideas and approach. So, retinal lymphomas are diffuse large B-cell lymphomas. And there are different subtypes. There's a germinal center B-cell-like lymphoma, and the activated B-cell-like lymphoma, and several grades in between. And with regards to the cause, we've just heard Paul Finger speaking, and a few years ago he described a cluster of vitreoretinal lymphoma cases in New York, and these were 6 out of 10 patients had lived in the Chernobyl area 23 years before, and so that might be a cause, because the incidence of vitreoretinal lymphoma is increasing. And then this is aggravated by HIV infection, and in these patients, there's evidence of a previous Epstein-Barr virus infection. So the question is, how does retinal lymphoma develop in the eye? Well, we had a patient a few years ago who developed vascular sheathing inferotemporally in the left eye. And that was followed by vascular closure. And the patient developed lymphomatous deposits throughout the fundus, except in the area of the retinal arterial occlusion. So this would suggest that the retinal lymphoma starts systemically somewhere, maybe bone marrow, nobody knows for sure, and it homes into the retina through the retinal arterioles. So from the systemic source, it reaches the retina, and from there it passes through the pigment epithelium into the subretinal space, sub-RPE space, where it gets trapped by Bruch's membrane. And some people have told me, how can the lymphoma cells pass through the retinal pigment epithelium? But retinoblastomas do the same. They can pass through the RPE, and then they get trapped by the pigment epithelium. From the retina, the lymphoma cells infiltrate the vitreous to cause these dense opacities, and from there they go back into the retina again. Then the optic nerve can get involved. You can get an optic neuropathy, and you can get extension into the anterior chamber. So the ophthalmoscopic features include a vitreous haze in many patients, vascular sheathing, vascular occlusion. Here's a vitreous infiltrates. You get these sheets of lymphoma cells, And then you can get the intraretinal infiltrates. They're not very common, but you can see them. And the infiltrates underneath the sensory retina, between the sensory retina and the pigment epithelium, and also underneath the retinal pigment epithelium between the RPE and Bruch's membrane. You can get very large subretinal infiltrates with a totally clear vitreous, and in these patients, most of these deposits consist of necrotic tissue, except near the choriocapillaris, where you can still have some viable cells. So that if these lesions are biopsied, it's important to go as deep as possible to increase the chances of getting viable cells. And in some patients, the vitreous is clear, the eye is quiet, and whenever you see the patient, you see that the scars, the infiltrates, are a little bit more extensive than the previous time. So this can progress in a very slow fashion in some patients. And after successful treatment, you get these retinal pigment epithelial scars, areas of RPE atrophy. And these are non-autofluorescent because there's no RPE and there's no lipofuscin, so they're totally black and autofluorescence. And you can see the gaps in the RPE on OCT. And here's a patient with optic neuropathy, you get optic disc pallor, severe visual loss. And then these infiltrates can spread to the anterior chamber to cause pearly lesions and a pseudo-hypopyon. Autofluorescence imaging is really valuable because it can show lesions that are invisible ophthalmoscopically or very difficult to see ophthalmoscopically. And when there are active lymphomatous deposits under the RPE, you get hyperautofluorescence. And when you have RPE atrophy, you get hypoautofluorescence. And then these infiltrates also in the vitreous are also hypofluorescent. And sometimes you see characteristic patterns of scars around the macula and so on. OCT shows the retinal infiltrates, and sometimes Jean-Paul has described these vertical lesions, opacities, as a sign of lymphoma, which can precede other features. And then OCT shows the sub-RPE deposits. And then you can get subfoveal scars, macular edema, and I've also seen epiretinal membranes in some of these patients. Now, in some patients, all you get are the vitreous infiltrates, and the pigment epithelium is normal. And in other patients, you get the sub-RPE deposits, and the vitreous is totally clear. And in most patients, you get a mixture of both of these. The differential diagnosis includes the infectious uveitis, non-infectious uveitis, and a variety of tumors. So the investigation includes a total clinical exam, history, visual acuity, slit lamp, ophthalmoscopy, systemic exam, imaging that I've just been mentioning, systemic imaging, blood tests, CSF tests, bone marrow biopsy, etc. But very important are vitreous biopsy, aqueous biopsy in some patients, and also sometimes tumor biopsy for histology, immunohistochemistry, clonality studies to look for IgH gene rearrangements. Then there's the cytokines, looking at the IL-10, IL-6 ratio, which differentiates lymphomatous infiltrates from from inflammatory infiltrates, gene translocations. Then you look for in various infectious agents and mutation, the MYD88 mutation, which is found in about 70 or 80% of these patients. And in San Francisco at UCSF, John Gonzalez, Taiduan and others in that team have developed metagenomic deep sequencing, which differentiates human from non-human DNA and can even identify the infectious organism, and is very useful for detecting lymphomatous abnormalities and diagnosis. With regards to therapy, there's different forms of treatment. Ocular therapy, there's external beam radiotherapy, and this patient is very effective, but you can get a recurrence. Here's a patient where the extensive retinal infiltrates disappeared after only one injection of intravitreal methotrexate. Usually this is given twice a week for a month, then once a week, and eventually less frequently. Very intensive treatment. And it can be good for recurrence after radiotherapy. And then there's monthly intravitreal melphalan, described by the Shields, which is effective, as we have found, but we've seen recurrences. And intravitreal rituximab. And then there's systemic treatment. Now, a big European study a few years ago concluded that systemic treatment for vitreoretinal lymphoma does not delay or prevent CNS lymphoma. As you know, most of these patients eventually develop CNS lymphoma, which is usually fatal. But they showed that they concluded that this does not prevent CNS lymphoma, and systemic treatment is also associated with more severe side effects and complications compared to local treatment. However, when I was in San Francisco between 2013 and 2018, in a clinic near mine, there was James Rubenstein, who specialized in CNS lymphoma. And so he sent me a few patients, and I sent them back to him for systemic treatment for the vitreoretinal lymphoma. And I was very impressed by the results that he achieved with our VR lymphoma patients. So first is induction with high-dose systemic chemotherapy and rituximab, then consolidation treatment, and importantly, maintenance therapy, long-term maintenance therapy. And then if there was a recurrence, then there was high-dose chemo and, if necessary, radiotherapy. Dr. Rubenstein was not in favor of total whole brain radiotherapy because it accelerated dementia. Most of these patients were quite elderly, and I've seen one or two patients develop dementia after whole brain radiotherapy. He preferred, if possible, to give focal radiotherapy just to the areas where the lesions were. And several years ago, he and others, and Paul Stewart, who was my predecessor in San Francisco, they reported resolution of vitreoretinal lymphoma with lenalidomide monotherapy. Lenalidomide is an immune modulator that somehow stimulates the immune system that has an effect on lymphoma. So here's a patient who, this is a system I developed for reporting progress in patients with vitreoretinal lymphoma. So red is for the right eye and blue is for the left eye. And the straight line, the continuous lines are the retinal deposits, and the dotted lines are the vitreous infiltrates. So this patient had a diagnostic vitrectomy in the right eye because there were moderate vitreous infiltrates and moderate sub-RPE infiltrates. And with systemic chemotherapy, that all disappeared, and the patient remained symptom-free with 20/20 vision. But an important ingredient of success was the long-term maintenance immunomodulation with lenalidomide and similar drugs. Because I understand that there are several who give high-dose chemotherapy and then they stop the treatment thinking that they've cured the disease, and then the disease comes back, and they speak about a relapse or a recurrence or recrudescence of the disease. Whereas Dr. Rubinstein understood that once you have CNS lymphoma, there's always minimal residual disease waiting to come back unless you keep it suppressed with long-term immunotherapy. And he showed that survival was much better after giving that maintenance therapy. So, but lenalidomide works with some kinds of lymphoma and not others. And therefore, it's important to know the subtype of CNS lymphoma, of vitreoretinal lymphoma, to know which type of systemic immunomodulation to give. But we found that although the systemic treatment was effective for the sub-RPE deposits near the chora capillaris, it was less effective for vitreous infiltrates. And these just persisted despite the systemic treatment. But here's a patient who presented to another hospital with vitreous infiltrates, and he had a diagnostic vitrectomy at that hospital, which caused a retinal detachment. And so he had a total vitrectomy, encirclement, and after that eye showed no sign of any vitreous lymphomatous infiltrates. Whereas in the other eye that had had no vitrectomy, there were persistent vitreous infiltrates that did not respond to the systemic treatment. And so we performed a therapeutic vitrectomy, and after that, the vitreous infiltrates responded to the lenalidomide and the vitreous remained clear. So here's another patient who could see much better after a diagnostic vitrectomy in one eye, and so she asked for a therapeutic vitrectomy in the other eye, which improved her vision long term. So there were about 12 patients, I think there were 10, 12 patients who I treated together with Dr. Rubinstein from the beginning until the time when I left. And they kept about the same, most of them kept about the same vision as they presented with systemic treatment and occasionally therapeutic vitrectomy, and in one or two patients, in a few patients, I don't remember the exact number, intravitreal treatment of some sort. In two patients, the vision improved because we removed the vitreous infiltrates. In two patients, the vision got worse. One because of complications after lens extraction, the patient developed a sort of uveitis, and another because of a subfoveal scar, which I showed previously. And then the remainder, the visual acuity was about the same as what they came with. And with regards to survival, none of them had died by the time I left San Francisco after about 5 years, although one or two had relapses that needed radiotherapy and so on. So there are new treatments coming along. There's these drugs that target Bruton's tyrosine kinase, such as ibrutinib and so on, which are showing efficacy with CNS lymphoma. And then there's these immune checkpoint inhibitors, nivolumab, pembrolizumab, etc., which are showing efficacy with CNS lymphoma, and maybe they might show the same with vitreoretinal lymphoma one day. So I'd like to say a few words about uveal lymphoma. This is totally different from the aggressive, large, diffuse B-cell lymphoma that you see with retinal lymphoma, because the uveal lymphomas are low-grade, indolent, mold, extranodal marginal zone lymphomas with a very good prognosis for survival. And here are the clinical features. on color photography. And the tumor, the disease is in the left eye, so there's a difference in the color. No significant difference on autofluorescence. On OCT, you can see the lumpy appearance of the tumor in the choroid, where all the choroidal vessels are obliterated or obscured by the lymphoma disinfiltrates. Whereas in the right eye, you don't have a lumpy appearance and you can see the normal choroidal vasculature. And then on ultrasound, you can see the diffuse thickening of the choroid, similar to diffuse choroidal hemangiomas, but with a low internal acoustic reflectivity. And quite a few of these show extraocular extension, not just in the orbit, but also subconjunctivally, where they form these salmon pink colors. And then you can get the lymphoma in the ciliary body. And then here's the patient with secondary lymphoma, patient with systemic disease. And a few patients show these infiltrates, these vitreous infiltrates, these choroidal infiltrates, which just sort of sit there without causing any problems, and they don't seem to progress, etc. So for these reasons, I think the term primary intraocular lymphoma is a sort of misnomer. First of all, we don't know if these tumors are primary or secondary. Even if they present with ocular disease, there might have been previous CNS lymphoma and previous deposits elsewhere. And secondly, the retinal lymphoma and the uveal lymphoma are so different from each other that they should be distinguished. So we've got the primary intraocular lymphoma, the retinal lymphoma, uveal lymphoma, and the retinal lymphoma is mostly vitreal, subretinal, and retinal. So in summary, there have been recent advances in retinal lymphoma, and these include the wide field imaging, autofluorescence imaging, OCT, the biopsy techniques, the laboratory studies, the intravitreal methotrexate, ocular radiotherapy, the systemic treatment, therapeutic vitrectomy for resistant infiltrates, and so on. So my personal belief, and I don't know if anyone agrees with me, but my belief is that the ocular treatment is only palliative, and that if there's any chance of improving, of prolonging life, it will be with systemic treatment, but only if administered by an experienced team of hemato-oncologists, an experienced nursing team, and so on, and if followed by long-term maintenance treatment. But patients will benefit from recent advances only if they receive early diagnosis and expert multidisciplinary care. So I'd like to thank you for your attention, and I'd like to acknowledge my colleagues, past and present. Thank you very much.
Thank you very much, Prof. One more time for your excellent talk. Always your talk are very educative. All of the times we learn something. And I've got one question for you. Actually, you mentioned it at the end. So you believe, from your experience, that with the local treatment we can achieve a local control, but you don't think we have any benefits on the survival rate of the patient, or what's your thoughts?
If I understand correctly, you're asking whether it's possible to prolong life.
Benefit on the survival of the patient, yeah.
Yeah. I think we need multi-center long-term studies to see whether ocular treatment ever prolongs life, and to see whether systemic treatment prolongs life.
Okay.
But my suspicion is that you need to give systemic treatment to prolong life in these patients, but we need further studies.
And in case of bilateral ocular disease, when we don't have any systemic involvement, would you stick on the topical treatment, as some of the guidelines of International Central Nervous Lymphoma Society, or would you add also a systemic chemotherapy, a systemic treatment?
The conventional approach is to treat bilateral disease, bilateral ocular disease, with ocular treatment. That's a conventional approach. But in San Francisco, we were treating them with systemic treatment and giving local treatment. Sorry, we're giving local treatment only as salvage treatment if the systemic treatment wasn't able to control everything.
Thank you. Thanks for being with us today. I hope to see you very soon. And thank you again for your presence today at today's episode of Ocular Oncology Happy Hour. Thank you.
Thank you.